liver enzymes were elevated. And her electrolytes were okay. Kidney function was normal. There you see her APRI was 0.603. Child tricho is 5. MELD score is 6. And her HIV test was negative. Her genotype is 1A. Her first viral load was 134,000. No, I'm sorry, I think that was the current one. The one in 19 was 764,000. Rheumatoid factor was negative, and there's her Hep C core antibody, Hep B core antibody. We have given her 2 vaccines for Hep B. She has an appointment to come back soon for the core antibody, surface antibody quantitative. So there you have it.
Thank you so much, Tammy. That was an excellent case presentation. We truly appreciate it. Any clarifying questions from the group as a whole for Tammy? Feel free to unmute or chat in.
Hey, Tammy. It's Jen. Nice to see you.
You too.
I'm not swift enough to know with that, with those labs, what was her fibrosis score?
Oh, let's see. 0.12.
And did they give you a score, like whether that made her fibrosis 0 or 1 or 2?
I'm pretty sure that was 0 on our scale.
I'm sure that Kaylee and other people know that, but anyway. And the other comment I wanted to make is I really like that you put marital problems as a comorbidity. I think that's really deep. I mean, it's holistic care. So anyway, that was just my other comment.
That's excellent. Thank you, Jen. Kaylee, was there something?
Yeah, no, I was laughing at Jen's because yeah, that's a good comorbidity to add. It's certainly important, but I don't know how to convert fibrosis scores in my head. I have to pull it up every time. So
good.
It is not something I would ever, and same with elastography. I still have to look at the values and convert them over. So don't ever feel like you need that. Okay. Why would you need that? You don't need that in your brain. So, but yeah, I pulled it up and it's F0 is what it correlated to. So I just had a couple questions for Tammy, and thanks so much for continuing to present. I think you're rocking, and you're really picking all the pieces that that I think about when I go through a case. But a couple things that came to mind. I'm not sure if you would even be able to get this information from her if you don't have it already, but just wondered if maybe her husband had been retested since he reported being treated, if there was any verification that he'd had follow-up testing to confirm he actually did achieve SVR. And then the other question I had was about her children, if you knew anything about if they'd been tested, and if they're not in her custody, that might not be something that you know, she'd be able to request, but you know, just didn't know if you had that information.
Yes, I checked on her husband's chart, and he has been treated, and is Hep C is not detected.
Awesome, great.
Yeah.
Thanks.
But I don't know as far as the children.
Okay. And I mean, in all honesty, in West Virginia, children in foster care, they should be screened. I don't think it's a state mandate, but it's kind of something that should be on just radar for general practice. If you have any children in foster care, that's just something to consider screening for you guys. But so Tammy, what was your, I guess, what's your thought process? What do you want to do with her?
Well, I would like to treat her, and I think that we could go with Maverick.
Yeah, I think, do you have a duration in mind?
I would say 8 weeks.
Yeah, wonderful. I think that's beautiful. You know, just remind her it's 3 tablets once a day with food. So she'd need to make sure she takes something, has something on her stomach with it. But I think that's an excellent plan, and she'll probably like getting that done with in 8 weeks as opposed to a little bit longer course. I did want to bring up, I know that you're very well versed in this, but since we have some new people joining in on the call, I do want to kind of just bring up the hepatitis B concept again. So I'm going to assume, because I know you wrote down her core antibody was positive, the surface antibody, was that did you do a qualitative and it was negative?
The qualitative was negative.
Okay,
Non-immune.
Gotcha. Okay, so just to bring up this concept again, you know, one of the things we consider with hepatitis C infection prior to treatment is hepatitis B co-infection, because there's that risk of reactivation with hepatitis B with our direct acting antivirals. And so we tend to worry about that in patients that have active hepatitis B or chronic hepatitis B, but also in our patients that have isolated hep B core positivity. And so in Tammy's case, this patient does have a positive hepatitis B core antibody. I'm assuming her surface antigen was negative, so this would be suggestive of prior exposure. The other part of Hep B serology we tend to check is the hepatitis B surface antibody to see if, although the patient's been naturally exposed, they have a good protective response. If they do have a positive hepatitis B surface antibody, that risk for reactivation is really benign. We don't tend to think of that with Hep C treatment. However, in the sense of an isolated core antibody, such as Tammy's patient, we do consider that there's an increased risk for flare, so that patient would need to be monitored closely for reactivation. Now, we kind of introduced this concept fairly recently, but potentially going ahead and immunizing our patients that have isolated core positivity to just see if we can produce an immune response. And then that may further decrease their risk of reactivation when they start treatment. So good job, Tammy. You did everything right. I just wanted to kind of explain that since we've got some new people joining today. So I don't know if anybody else has any questions or comments.
Thank you so much, Kaylee. Yeah, anyone who has any questions, comments, like Kaylee mentioned, please feel free to unmute at any time, chat in. I can read off the chat for you if you'd like.
Thanks, Kaylee.
And Tammy, were there any other questions that you wanted to have addressed with the group as a whole?
I don't think I have any right now.
Sure. Dr. Gilfus, I noticed you unmuted there.
Oh, it was accidental, but no, I think Kaylee did say everything that I would have wanted to bring up. Yeah, I'm pretty sure that this is going to be one of those situations of concern where you have serologically silent Hep B going on, and getting the full panel like we talked about is a good idea. I'd be very interested what those results look like when we get them all back, including the PCR. And then just because there are a bunch of new people on, I know we settled on Maverick, genotype 1A with a low viral load. So remember the other options, the other treatment options. Epclusa 12 weeks. Harvoni for 8 weeks would be an option. Or Zepitir, but because it's a genotype 1A, you'd have to do an NS5A polymorphism test ahead of time. So in general, that's not one of our go-tos. So genotype 1A, a lot of choices. The 4 primary workhorses are all options, but clearly choosing an 8-week duration always is more appealing.
So I do have a question about this Hep B flare. How would you monitor for that? I mean, would it be symptoms and then would you monitor those LFTs more frequently, or what are you doing there?
Good question, Jen. So in this case, you know, since she does have baseline core positivity, I would go ahead and check a Hep B baseline DNA PCR test to see, because sometimes you can have a surface antigen negative and still have active viral load. And so establishing kind of what the baseline is, sometimes you can have a silent flare to where you might just see a fluctuation in the viral load without any symptoms. You might notice ALT elevation or transaminase elevation, but also certainly just kind of counsel the patient, hey, this is a possibility, and then monitor for signs and symptoms of flare, jaundice, appetite loss, you know, everything that we tend to see with the acute flare. Now, my approach is typically to monitor their transaminases more closely. There's not really specific guidance. I do tend to just do a liver panel at treatment week 4. If a patient has more advanced liver disease, you may even want to consider it at treatment week 2, or certainly to have them let you know if they have any clinical symptoms, then to test sooner than that. You can trend a hepatitis B DNA. What you would do with that, I don't really know. You know, you wouldn't necessarily opt to treat their Hep B based on just the DNA elevation, but if it's kind of one of those things that just my own interest, I've kind of like to watch just to see if there's an increase in elevation even without symptoms and transaminitis. So that's kind of more of a should you know, but you know, really you should just trend it with hepatic panel. And symptoms, certainly. But, you know, there's not really a suggested amount. It just says close monitoring. So I tend to do it at 4 weeks. And then, you know, since they're on such a short duration too, remember too, it can even be after Hep C treatment. So that still might be someone that you want to do a liver panel again at end of treatment, and then maybe even sooner than that, 3 months, because it's really once Hep C is clearing, since they both Hep B and Hep C are competing for the same hepatocyte receptors, that once this Hep B or Hep C, I'm sorry, is clearing, that's when you see the reactivation. So typically viremia is already undetectable even as soon as a couple weeks into treatment. So when you know, but you could certainly still see flare even after that. So I would monitor hepatic panel, I'd say about at least monthly.
Yeah, I'm going to agree 100%. Kaylee's clinical approach, it's also what I would do as well. And I want to reemphasize the point that she made that's incredibly important. And remember, a Hep B flare in and of itself is not the end of the world. But it can be if your patient has a high level of fibrosis at baseline. So when a Hep B flare becomes dangerous is really when you're talking about a patient who is borderline compensated. So somebody who is a compensated cirrhotic, I would be really scared and worried in those situations, and probably check liver enzymes, liver functions, et cetera, very frequently. Furthermore, remember that not all Hep C drugs are the same with regard to risks of decompensating patients when they already have cirrhosis. So we try to avoid the protease inhibitor groups in that scenario. In this scenario, we have nothing that suggests advanced fibrosis. Young lady, friendly fibrosis scores, APRI does not suggest it. So, but just remember that's the context of Hep B flares being a worry and being potentially deadly or dangerous is when you have pre-existing significant liver damage.
Thank you all so much. Dr. Exford, was there a comment you wanted to make too? Or am I just calling out people when I see them on mute by accident? I do apologize. Oh, Dr. Exford, I don't know if we can hear your audio. No. Feel free to chat in, and if you wanted to change your audio source, you can just hit the little upward caret by the mute button to change the audio source there. Did anyone else have any other comments or questions about the case or anything related to the case? All right, well, thank you all so much for the awesome comments and feedback and recommendations. And thank you, Tammy, again for that great case presentation. If you ever want to present a follow-up as well, we would be happy to have that and see, you know, down the road about this case as well. So,
Okay.
all right. So if there's nothing else with the case, we can move on to the didactic portion. So Kaylee, I can pull up your didactic PowerPoint for you and just let me know when you'd like me to advance the slides for you.
Awesome. Thanks so much, Mitra. So I'm going to kick off our new year for Hep C ECHO with a revisit of the initial hepatitis C evaluation. And for those of you that have been joining us for a while, you could probably give this didactic. Jen, you're one of them. I bet you could. But actually, a lot of the providers that are on here right now probably could. But if you're new to ECHO, this is just a quick overview. And so as we kind of advance through our ECHO sessions throughout the year, we'll be delving into more of these specific areas in depth. And so just, you know, if there's any questions at the end, we can certainly we'll have room for discussion. I tried to condense it as much as I could so we can talk further at the end and I can clarify anything that might be a little unclear to anyone that's new, but otherwise let's get started. So go ahead, Mitra, if you don't mind advancing. So objectives today are to review the updated hepatitis C screening recommendations, differentiate between acute from chronic hepatitis C, consider the clinical manifestations of Hep C, review our initial workup and testing, understand the importance of liver disease staging, recall our cofactors for disease progression, and then discuss some patient education topics. Can you guys hear me okay? Because I'm on a new, okay, I didn't know.
Perfectly.
Usually I have my headphones in and I don't know how to plug them into this computer. Go ahead, Mitra, if you don't mind advancing. So the current HCV screening recommendations are for one-time routine opt-out screening for everyone 18 and up, for pregnant women with every pregnancy, and then risk-based if you're under 18. And this is fairly new. So for those who have kind of been in on our ECHO session since we started, when we first started, it was really risk-based screening, and then had kind of progressed to risk-based plus specific birth cohort screening. And so really the HCV guidance that we tend to refer to in our ECHO sessions, which is based on the AASLD and IDSA joint guidelines, have kind of had this routine one-time universal testing for a while. However, CDC and the United States Preventative Services Task Force just adopted similar guidance in spring of 2020. So I think March and April sequentially is when they kind of got on board. So that's a great thing because now HCV screening is covered by insurance. Since it's part of a preventative recommendation, it's now paid for, which is great. But basically screen everybody. And then if there's any concern for ongoing risk factors, screen them again. So that's kind of the concept here. We tend to do hepatitis C screening through an hepatitis C antibody, unless a patient's immunocompromised. And when I mean this, I'm talking about certain HIV positive patients, particularly those with a low CD4 count, or patients who are on hemodialysis. Sometimes in that instance, they won't develop a HCV antibody, and so HCV RNA is recommended in those cases. Usually an antibody is detected within about 3 months, but 2 to 6 months they tend to develop, and then RNA is typically developed as soon as 2 to 3 weeks after infection. Next slide. So I listed some, I made a pretty table of hepatitis C risk factors. Now, even though we're doing universal screening now, there are still some instances where you would want to perform periodic follow-up testing or follow-up screening. And so I try to kind of cluster these into separate groups. Does it really matter? No, but it's kind of just nice. I like to have things a little bit better stratified. So I grouped them amongst risk activities, which include injection drug use, intranasal drug use, and then high-risk sexual activity. As far as sexual activity, hepatitis C transmission is generally low risk, but with certain populations, so those that have HIV infection, particularly MSM with HIV, there's a higher risk of co-infection. In addition, it's recommended now that our PrEP patients, so MSM patients that are on PrEP, be screened annually for hepatitis C, as well as HIV positive men who have sex with men. So risk exposures, long-term hemodialysis, even if they were on it 20 years ago, should be tested at least once. If they are continued on hemodialysis, then they should have, recommendations kind of vary, but typically every 6 months they're screened. Unregulated percutaneous or parenteral exposures, this could be tattoos in an unregulated setting. It could be a medical procedure, either before standard universal precautions were in place in the US, or if someone has gotten a medical procedure outside of the US and in a Hep C endemic area. Also could be air gun immunizations. Some of our veterans received air gun immunizations while in the service, and this was before HCV screening, so could have been a mode of transmission. Children born to HCV infected women should be tested. Those who've received a blood transfusion before '92, any solid organ transplant recipients, anyone who's ever been incarcerated, and that's even once, even less than 24 hours should be screened. We talked about other circumstances, HIV infection. There tends to be about a third of those that have HIV infection have HCV co-infection. Patients with chronic liver disease or those with unexplained ALT elevation, you should consider screening. Solid organ donors, pregnancy we talked about, and then anyone that has extrahepatic manifestations that can be associated with HCV infection should be screened if they haven't already. And there's a slide I have in the future about that. So I just kind of like to use this, not, we're screening everybody once, but there's some instances where you should consider it again. And then sometimes patients, once they're diagnosed, have no idea where they got this infection. And so it's kind of nice to review these with them just to kind of help them get that peace of mind. This is a really common virus. But sometimes they just kind of want to know where the heck they got it from. So next slide. All right, so after you've established a diagnosis of hepatitis C, the second step is establishing the chronicity of their Hep C infection. I tend to do this by coming up with an exposure history timeline. This is important because you treat someone that's just been recently infected with hepatitis C or possibly has acute hepatitis C much differently in terms of management as somebody that's had this disease for 30 plus years. So I try to assess risk factors and then go even more specific as saying, when is the first time that you ever injected? When's the first time you might have gotten a tattoo or shared works? And then when's the most recent time that happened? Really establishing that timeline can help you kind of get a quick assessment of how concerned you should be for underlying liver fibrosis. Hepatitis C, it progresses, the natural history, it progresses over decades, not just days. And so someone that's just got a new diagnosis, but the only risk factors you identified were from 30 years ago, you'd be a lot more concerned about them having underlying, possibly undiagnosed liver fibrosis than someone who's 20 years old, injected for the first time 6 months ago, and is coming in to see you for hepatitis C. Once I have that kind of timeline of what time frame have your possible exposures could have fallen in, then I ask if they've ever had any prior Hep C testing or prior negative testing, and that can kind of help narrow down your timeline of infection or a little bit more. Remember that only a third of patients actually develop symptoms of acute hepatitis. They usually develop around 8 weeks after exposure, but it can be anywhere from 2 to 26 weeks. And then there's also a chance of spontaneous clearance. Initially, we kind of said that this was really fell under about 15 to 25% of those that had hepatitis C exposure, but now studies are suggesting it can be as up to 45% actually can spontaneously clear. And I think that's kind of changed once we've adopted more widespread testing or widespread screening measures. Most often, if someone's going to spontaneously clear hepatitis C, it'll be within the first 3 months, but it actually can occur up to even a couple years later. kind of by treatment standards in the US, even though it's recommended to treat all patients that have hepatitis C unless they have a prognosis less than 1 year, really a lot of insurances tend to cover hepatitis C treatment once persistent hep C viremia has been established over a period of 6 months. And so they kind of want you to wait for a little while before you treat just to see if they may spontaneously clear. Next slide. All right, our clinical manifestations. So just recognize this is usually asymptomatic. If patients do complain of hepatitis C, unless they have really end-stage decompensated cirrhosis or come in with acute infection, you're not going to see the jaundice. You're not going to see those kind of scleral icterus, those kind of symptoms. It's typically going to be, hey, I'm feeling tired and I can't sleep. And probably if we ask every patient, they're going to say they're tired and they can't sleep. So it's hard to kind of differentiate if it's from untreated hep C or something else. But you might also see patients that are having this kind of unexplained abdominal pain. Sometimes they'll say liver pain or liver twinges, or on the right side, they might have some nausea, appetite loss. Joint pains is another big one, and it's kind of just generalized achiness or feeling unwell. We see a lot of neuropsychiatric manifestations as well in terms of even depression, anxiety, brain fogginess, and then once hep C has been treated, they actually feel like they have more kind of clarity, mental clarity. Patients may also present with stigmata of chronic liver disease. So you may see pulmonary erythema, you might see muscle wasting, and that's kind of generalized through any patient with chronic liver disease, not specific for hepatitis C. Just understand that chronic hepatitis C is also associated with many extrahepatic manifestations, and these can occur regardless of fibrosis stage. So specific examples include mixed cryoglobulinemia. If anybody is diagnosed in your clinic with mixed cryoglobulinemia, you better be checking for hep C. I mean, it's upwards of 90%. In some studies, even 100% of mixed cryo have underlying hep C, which is a lot. Porphyria, leukocytoclastic vasculitis, lymphomas, diabetes, glomerulonephritis, and then certain autoimmune disorders as well can be associated with hepatitis C. Next slide. So our initial testing, certainly our hepatitis C viral load in the form of an RNA PCR. We also check a hepatitis C genotype. CBC, CMP, INR, hepatitis B serology. We already discussed today about the specific components, so I won't go over that again. HIV testing, hepatitis A antibody, and then consider an IgM for hepatitis A if they have recent risk factors or transaminitis, vitamin D, and then a fibrosis assessment. And this I'll discuss on the next slides, but can be in the form of imaging as well as biomarkers. Next slide. Also consider if you're looking for extrahepatic manifestations or someone's presenting with symptoms, you might want to check serum cryoglobulins. Rheumatoid factor can be falsely positive with untreated hepatitis C infection. So a patient that may have unexplained joint symptoms, instead of pursuing a big rheumatology workup or sending them off to rheum, you might want to check a rheumatoid factor and CCP. And with hepatitis C, we tend to see positive rheumatoid factor and then negative CCP. Consider checking thyroid studies. In some instances, you may want to look for other chronic liver disease, particularly iron overload with Caucasian males, performing an autoimmune hepatitis workup. Urinalysis, you may want to consider a urine tox screen, pregnancy screen, or STI testing if applicable. Next slide. All right, so establishing the degree of liver fibrosis is extremely important. This is imperative. The risk of liver-related morbidity and mortality in an HCV-infected patient increases with the severity of fibrosis. We tend to utilize multiple modalities to assess the degree of liver disease unless cirrhosis has already been established. So liver biopsy is still the diagnostic standard, but it's invasive and we don't typically perform this with hepatitis C monoinfection. I've been doing this since 2015, I think, and never ordered a biopsy for hepatitis C. So we have multiple non-invasive modalities that we tend to prefer due to the complication risks, as well as kind of technical error with performing liver biopsies that kind of give us the same information. So quick calculations, you can do an APRI and FIB4, serum biomarkers, and this is measured either through a fibro test or FibroSure. Those are the brand names available in the US. And then our imaging modality. A liver elastography or Fibroscan is preferred. If unavailable, then a regular right upper quadrant ultrasound should suffice in most cases. Next slide, please. Oh, wait, go back. That was important. I want to point out that, sorry, I missed that. The degree of hepatitis C viremia does not correlate with the severity of liver disease. And so that's different with HIV and hepatitis B infection, where you kind of consider the severity of disease or disease progression or response to treatment by the level of viremia. Hepatitis C viremia, it's such a fast replicating virus. You could draw 2 samples back to back and have widely differing amounts of viremia. And so sometimes people will get referred and you'll check their viral load and it's 100,000, and then they come in 3 months later and it's 3 million. That has no importance. Either they have it or they don't. It's important to kind of know if they have it or they don't, but the only time that we tend to trend viremia is in the case of acute infection for spontaneous clearance, or if somebody's just entering care with you to confirm infection, or in some instances with pregnancy, you may monitor it more closely because there is a higher risk of vertical transmission with a higher viral load. Next slide. All right, so your APRI, and this is an AST to platelet, it's supposed to say ratio, not ration index. This is just a quick test you can do from a CBC and a hepatic panel. And so if you're assessing, seeing a new patient and assessing them for hepatitis C, fibrosis, you can do this. You probably already have these results available to you the first time you see the patient. So, you know, the calculations here, I use the MD Calc app, which I put down in the corner of the screen, but you're basically just taking your AST level, dividing it by the upper limit of normal AST, and then dividing that value by your platelet count and multiplying by 100. If it's a value less than 0.7, they're very unlikely to have significant fibrosis. There's a greater than 90% negative predictive value, and then greater than 1, we tend to be more concerned for advanced fibrosis. Greater than 7 is kind of our threshold, but if you kind of think about, we're using multiple modalities, and so greater than 1, you have a much higher likelihood of underlying advanced fibrosis being present. And so I kind of go by that threshold rather than 0.7 unless multiple modalities are suggesting advanced fibrosis. Next slide. And then the FIB4 index, this is another calculation to assess fibrosis. That's also quick calculation with your AST, ALT platelet count, but also factors in age. Less than 1.45, they're very unlikely to have advanced fibrosis, and then greater than 3.25, likely to have advanced fibrosis. There's a little bit of variation with cutoff values in those over 65, but I think we do a talk on genotyping and fibrosis in a month or so, and so we'll go into that in more detail then. All right, next slide. With our fibro test, Fibroscan or liver biopsies, these are different markers that actually give you fibrosis staging, either in the form of a numeric value with an interpretation, or you can look it up yourself. Many times they use the Medivir scoring system. There's a few other scoring systems as well, but the one that we tend to see is the Medivir score, and this is what they tend to use with the liver biopsy. F0 would be considered no fibrosis at all. F1, portal fibrosis without septa. F2, portal fibrosis with few septa. F3, numerous septa without cirrhosis. And then F4, cirrhosis. Next slide. The importance of this is that if you have a patient that has F3 or F4 with these modalities, they need to be screened for hepatocellular carcinoma. Next slide. So surveillance screening, as I just said, in patients with Hep C and advanced fibrosis, either stage 3 or 4, screening for hepatocellular cancer is warranted, and this is at 6-month intervals. This is even after their Hep C has been treated. Typically, you can do this through a right upper quadrant ultrasound. At our facility, we tend to do a right upper quadrant ultrasound as interval screening plus an alpha theta protein. The alpha theta protein has not been recommended with the AASLD guidelines. I'll tell you that because it's not specific for HCC. The reason that I still tend to check it is that in a patient that has cirrhosis, mass might not quite be detected on an ultrasound. It may be too small, but if you notice a fluctuation in the AFP, so let's say it was 10, 9 is the normal value, let's say it's 10, and then the next time you check it, it's 300, and I have a patient that has cirrhosis, then I would probably do an MRI liver protocol for them. So I still check it, but typically right upper quadrant ultrasound is what's recommended. In addition, in your cirrhotic patients, an EGD as an esophageal varices screening is recommended. In some instances, you can defer this. So if a cirrhotic patient, or you've labeled a patient as cirrhotic, because remember, we're not doing biopsies on everyone, so we're kind of giving our best shot. But in a patient that's been labeled as cirrhotic or F4, if their platelet count is over 140 and their liver elastography value is less than 20 kilopascals, there's a much lower chance of variceal bleeding. And so you can defer that EGD since it's another invasive procedure. But I do recommend at least getting your gastroenterologist or hepatologist on board for EGD if you find out a patient is cirrhotic, and then they can do the screening protocol. It tends to be like every 2 years if they don't have any underlying varices present. Next slide. Some cofactors that increase the rate of fibrosis progression. Obviously fibrosis stage, if you have somebody that has no fibrosis or somebody that has cirrhosis, you're at higher risk of decompensation the higher the stage. Fibrosis also progresses non-linearly. So once that fibrosis has already been established, it's kind of off the table as far as how quickly it will progress to the next stage. Persistently high inflammation grade can also increase the rate of fibrosis progression. You'll see this with your fibro test or FibroSure. It's identified as a necroinflammatory grade. It gives a category of A1 to A3. A3 would be a high necroinflammatory grade. Somebody that has persistently elevated transaminitis for a prolonged period is at higher risk of fibrosis progression. Older age at time of infection, so generally over 50, if they get exposed to hepatitis C, have a higher rate. Metabolic disorder, and this is more in the terms of associated fatty liver disease development that can also increase the rate of progression. Men and postmenopausal women progress as well at a faster rate. Premenopausal women, remember estrogen has this protective effect to the liver. And so there actually have even been some studies that hormone replacement therapy in postmenopausal or perimenopausal women can decrease the rate of, or I'm sorry, should halt the rate of progression, not necessarily reverse what's there. Genotype 3, immune suppression, and this is with solid organ transplants or HIV infected patients. With HIV infection, you know, the biggest thing is getting their HIV under control, and that can help kind of decreasing that HIV viral load burden, can help with reducing the rate of liver progression from Hep C. Immune suppression, agents that we use for as immunosuppressives, like I'm trying to think of some, and my mind's just blanking, like methotrexate, not necessarily methotrexate. I can't think of any right now, but we tend to think of certain immunosuppressive agents. With hepatitis B can have a negative compounding effect. With hepatitis C, there's really no correlation. So you may have someone that's kind of worried about starting an anti-TNF agent or something because of HIV or HCV progressing, or even chemotherapy, wanting the HCV to be treated first, and that there hasn't been any data to suggest that there's a negative effect with fibrosis progression in that instance, sorry. And then I mentioned HIV or HBV co-infection previously. Also, alcohol consumption certainly can progress your rate of fibrosis progression. I use the analogy of throwing gas on a fire as like alcohol and Hep C, so it can really flame up your liver a lot. There have been some studies also to suggest that marijuana use has a role in advancing fibrosis. Some protective factors to consider: coffee. I don't know if we've talked about this before or not, but there's some kind of more recent studies that have suggested drinking coffee, so caffeinated coffee, not caffeinated tea or decaffeinated coffee, but 3 cups of coffee a day can have a protective effect for your liver, and then as well as statin use. So sometimes there's some caution with providers for treating hyperlipidemia with a statin, or using a statin in those that have liver disease. And it's actually, unless their liver enzymes are 5 times the upper limit of normal, or they're decompensated cirrhotic, a statin is safe and actually can be protective. Next slide. Vaccinating your patients with hepatitis C, really whatever's recommended for an adult should do for your Hep C patients. In addition, hepatitis A, hepatitis B vaccination if they're not already immune, and then pneumococcal polysaccharide vaccination is recommended in those that are even younger than 65 for any patient with chronic liver disease, and that includes hepatitis C. And then certainly flu vaccine, and then tetanus as well. COVID-19 vax when it is available to everybody. I'll put that on there too. Next slide. All right, just a couple comments about hepatitis C in pregnancy. Approximately 6% of infants born to Hep C infected women become infected. There's not any known strategy to decrease this risk for HCV monoinfection. So if you have a patient that's HIV and HCV co-infected, controlling again HIV viremia can also reduce the risk of HCV vertical transmission. Certain variables may increase the risk of vertical transmission above that 6%. HIV, again, that's not controlled. Hepatitis C viral load that's greater than 10 million. Active drug use. HCV acquisition during pregnancy. And then some studies suggest invasive procedures like scalp monitoring, amniocentesis should generally be avoided if possible. A C-section is not indicated, so vaginal delivery is fine unless there's some other reason that a patient needs to have a C-section. There are not currently any Hep C treatments approved in pregnancy. There are very small studies that are being conducted with Hep C treatment in pregnancy, but they're all, one I saw was like 15 patients had Harvoni, and then another one, it was like 20 patients with Epclusa. And so they're very, very small studies. SVR rate has been the same. And there hasn't been any negative effects noted so far, but that's still very early. So right now there's no guidance as far as approved with pregnancy. If you have a patient that is on Hep C treatment and becomes pregnant, then that would be, while they're on treatment, that's gonna have to be a case-by-case discussion whether they wanna continue or not. There hasn't been data to suggest that it has stopped, and many times by the time that they find out they're pregnant, they're finished with their Hep C treatment anyway. But the goal is really to get them treated before they become pregnant. Patients with Hep C who are on treatment should avoid breastfeeding, just because we don't know how Hep C direct-acting antivirals are, if they're transmitted through the breast milk. And then those that are not on treatment, though, can safely breastfeed. So as long as a woman is not doesn't have any active cracks or fissures or bleeding in her nipple, she's certainly fine to breastfeed. It's not transmitted through breast milk. Let me see if there was anything else I wanted to mention. I think that was it. Oh, there is about a 10% chance of spontaneous clearance with hepatitis C in pregnant women. So I don't know why, but that tends to sometimes happen. So you may want to screen a pregnant woman early into pregnancy, and then also consider even rescreening a patient who may have been negative but has ongoing risk factors closer to term. Or they may spontaneously clear. Next slide. Patient education. So just educate your patients on the natural history of hepatitis C disease progression. I tend to use the rule of thirds. You know, 1/3 of patients will develop, who have hep C will develop chronic liver disease. 1/3 of those patients will develop cirrhosis, and then 1/3 of those patients, will develop fibrosis, and then 1/3 of those patients will go on to develop cirrhosis. Counsel again that it takes decades, not days, for hepatitis C to cause significant liver damage. However, once fibrosis is established, it progresses non-linearly. Also, with hepatitis C treatment, fibrosis can improve or even resolve. The goal is to halt disease progression, but even with cirrhotics, there's been studies that up to 50% of HCV-associated cirrhosis can improve. The risk of developing cirrhosis really ranges from 5 to 25% over a period of 20 to 30 years. There's about a 5% increased hepatocellular carcinoma risk for patients with hepatitis C. It does not develop unless they have cirrhosis, and that's why we screen with advanced fibrosis, but we don't necessarily do surveillance screenings in those without fibrosis. Next slide. I think I'm about done. A comment just about HCV in the setting of drug use. There's a good study, Dr. Gilfus found this one, but it was a good study that he uses, and it's really stuck with me, that often it's the patient's addiction that causes the most harm. The leading cause of death in patients with hepatitis C was not related to their liver. It's related more to drug overdose and suicide. So I think that's an important conversation to have with your patients as well. If they're in active addiction and they recently get diagnosed and they're very anxious over their hep C diagnosis, it's kind of good to take a step back and also kind of remind them that this is not something that can cause them detriment quickly, however their drug use can. Active drug use is not a contraindication to hepatitis C treatment. There have been studies that show that efficacy with in achieving SVR with patients that are in active addiction that start DAAs are very similar to those that don't actively use. However, this is on a case-by-case basis. Payer restrictions, often they have sobriety restrictions that kind of limit us in treating patients with active addiction. The thing to consider though is that the real goal is towards total HCV elimination, and so treating those in active addiction who are the riskiest for forward transmission can reduce that forward transmission risk. And then certainly in those with active drug use, you want to continue assessing them for hep C reinfection risk if they are treated. Next slide. I think I have two slides left. So transmission amongst patients with ongoing drug use, education should really be not just aimed at certainly cessating drug use, but counseling on harm reduction practices. So utilizing syringe exchange programs if they're available, avoiding reusing or sharing needles, syringes, any part of drug paraphernalia, because that's really what's transmitting hepatitis C. It's not the drug use itself, it's the sharing of paraphernalia. In addition to not sharing intranasal works. Sexual transmission, just remember that hep C infection in itself is not transmitted efficiently through sex. It's not really cited as a reason to change sexual practices if they're monogamous. So you don't have to use condoms if you're in a monogamous relationship, but condom use does prevent transmission for Hep C, HIV, and other sexually transmitted infections. And so with patients that aren't in a monogamous mutually monogamous relationship, make sure to still counsel those. And then certainly men who have sex with men are at a little bit higher risk. Next slide. Blood donation, sorry, but even after your Hep C is treated, you can't donate blood or semen. They just use the screening antibody to test blood products, so they would still discard it. So you'll have to let your patients know that they still won't be able to do that. Prevention of transmission to household contacts. Make sure to avoid sharing toothbrushes, which some people do that, I don't know why, or other dental devices. Don't share any sharp items for personal hygiene, like razors, shaving equipment, nail clippers, anything like that. Make sure that you counsel patients to cover their wounds if they have any open wounds. And then Hep C virus can survive on a surface for up to 3 weeks. So if they get injured and they get a blood spill on a surface, they should be wearing gloves, or if somebody has to help them, that person should be wearing gloves, just universal precautions. And then a surface should be cleaned with a combination of bleach and water solution if it's contaminated with visible blood. And then certainly avoid tattoos and piercings unless they're performed in a regulated setting. Next slide. Avoid alcohol. That's all I'm going to say about this one. Yeah, that's it. You can use Tylenol if you have hepatitis C. That's a question we get a lot too, is somebody told you couldn't use Tylenol because you had Hep C. You can just reduce it to about half what the recommended daily dosage would be if you did not have Hep C, so about 2 grams over a period of 24 hours, unless you have significant transaminitis, then I would avoid it completely. And then NSAID should be avoided in those at risk for GI bleeding, so cirrhotic patients. Next slide. So planning for treatment, so your initial evaluation, that's going to be the big question, is patients going to ask you when they can get treated. Kind of got to walk before you run, but just these are some kind of things to discuss with your patient. And so this is, again, your initial evaluation, but these are kind of topics to maybe revisit with them as your in each session until you're able to get them treated. And I think that's it.
Yes, thank you so much, Kaylee. That was awesome. Any questions for Kaylee? I know we have about a minute or so left, but I wanted to open up for any comments, questions for Kaylee in the didactic. Sure.
I had a quick comment if there aren't any other questions. Kaylee, great job. Obviously, if the fellows listening on today can emulate that on the initial assessment of your Hep C patients, you're going to be doing great. Kaylee, you brought up something that took me down memory lane, and that was protective effects of fibrosis progression. Back before the direct-acting antivirals, people were not excited about interferon therapy. So sometimes they would ask what they can do if they didn't want to have treatment. And of course, telling them to avoid the things that we know speed fibrosis up, like gaining weight and using alcohol and immunosuppressants and stuff like that. There were 3 things we used to tell people could slow down fibrosis. One of them was coffee. So coffee, blueberries, and go sit in the sun. So that was literally the advice we would give to people who didn't want to. Don't drink alcohol, try to maintain a good body weight, eat blueberries, go drink your coffee, and get vitamin D via sun. Anyway, I just thought it was funny and a cool memory about the coffee thing. I don't think we ever talked about that before, so appreciated that recollection.
Yeah, was this when you practiced in the 90s?
Shut up. No, but no, listen, I found it in a folder, a little 3-ring binder of mine, remember? I'm just
that's not even fair. Everybody has a 3-ring binder but you.
Yeah.
No, I think when we talk about vitamin D too, because we list that on our kind of basic lab work, and we talk about replacing vitamin D. But yeah, it's just important, in addition to immune. Dr. Rexer. No, I'm just teasing him because I was off with how long he'd been practicing by I think a decade or so. But we talk about, replacing vitamin D, but we don't, and for kind of immune support, but we don't really talk so much about the protective effects to the liver as well. And so that's a good point to bring up. I hadn't heard the blueberries though.
Yeah, I hate to interrupt, but we did get a chat question asking if you can be an organ donor once treated.
And you can be an organ donor before you're treated. So, so yeah, I mean, this is kind of fairly recently, but they actually are transplanting Hep C positive infected donors into non-infected patients now in some instances, and the area I tend to bring up is with liver transplants, because there's just such a high need for liver transplants. So they can transplant a healthy Hep C infected liver into somebody that needs one, and then treat the Hep C afterwards. And so one of the things we think about when we say don't treat a decompensated cirrhotic, in addition to kind of not decompensating their cirrhosis further, which sometimes certain DAA medications can, like the protease inhibitors, you also kind of don't want to treat somebody for hepatitis C when it's going to improve their MELD score to where they're not going to be a transplant candidate anymore. So you might actually be doing them more harm in getting their priority for a new liver. And so that's a really, really good point to bring up. Thank you so much for mentioning that.
Thank you so much. So we are a little over the session time, so I do apologize, but I wanted to give a big shout out to both Kaylee and Tammy for starting us off so strong in the new year with this, the great session. So thank you both so much. And thank you all so much for joining and being so engaging and participating as always. I can't thank you all enough. So the next session will meet on January 28th, and Dr. Gilfus is going to be talking about HCV HIV co-infection overview. So keep an eye out for that reminder. Happy New Year, and we'll see you all next time. Thank you guys.